point, I'd like to bring the board meeting to order for the Public Employees Benefit Board on Tuesday, April 21st. First thing on the agenda, of course, is roll call. And I believe we have Sean. Yeah, I see Kiki online. Andrea.
Present.
Thank you. I see Kimberly. I see Siobhan.
Hello.
Dawn. Emily Wang. Emily, are you here?
Yeah.
Yes, oh, you're there. Yes, I saw you out front. And we do have Rep No, so we have a full board today. Thank you all for making it. I appreciate it.
I have to leave at noon, but I'm here.
That's fine, sir. Thank you. Of course, after being called to order, the first thing is meeting minutes from March 17th. Are there any questions or comments on the minutes as presented or written? Hearing none, I'll entertain a motion on those minutes.
I will make a motion with Siobhan to approve the minutes as written.
You. Second. Right, we have a first and a second. If there's no other questions, then all those in favor say aye.
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 Any opposed? All right, that motion carries. And with that, we are running a little behind, but that's not too bad. We'll run it. Start with the VSP engagement update.
Good morning, everybody. Sorry, I'm having a little bit of issues with my camera, but we got that set up. I hope you are all doing well, and thank you for the opportunity to come and present to you a member engagement update for the 2026 programs geared to promote benefit utilization. We're first going to start off with a little bit of a look at the utilization in your member savings. We're going to dig into that plan use, enrollment, negotiated discounts. Then we'll go into member engagement, talking about how it is we can help to promote vision benefit awareness and utilization. And then we'll get into some information about the network, specifically in the rural network and access, and then resources and ways in which we're able to help those members without access receive care. And then we'll follow up with any questions that you may have. Right. So overall, enrollment is increasing just slightly, but the key drivers for increased premium of 3.7% in first quarter 2026 versus first quarter 2025 and the 5.2% in 2025 versus 2024 is increased enrollment in the Plus plan. We are now at nearly 50-50 in the basic and the Plus plan. And if for those of you who don't recall, the Plus plan is a buy-up. Your members pay a little extra in order to get a richer benefit that allows them to have a frame that is $225 allowance or contact lens allowance of $225. And then also there's some coverage for some lens enhancements such as premium and custom progressives with a $20 copay and anti-glare coating with a $20 copay. These things are very valuable in that when people are going out looking to purchase materials, they're looking to see what are my out-of-pocket costs going to be. And so that's driving them to make this change is that they're seeing increased out-of-pocket costs, you know, for frames, but also for those lens enhancements. And so we're going to dig into the value of VSP a little bit and why these extra values are so valuable and the money that they are saving your members. So in the last 12 months, as of March 2026, the VSP guarantees and negotiated discounts saved members a total of almost $6 million in out-of-pocket costs. And some of the ways that is taking place is the negotiated discounts that we have on non-covered lens enhancements of and that was about 49% savings. There was over 43,000 non-covered lens enhancements that were selected. That gives you a little bit of an idea of how important these are. There are things such as UV, polycarb, and high index lenses. Those were the top three. And then the lens enhancements that you are covering are the anti-glare with the $20 copay, progressives with the $20 copay, and polycarbonate covered in full for children. And that had almost a $3.7 million savings, 90% savings in out-of-pocket costs for a little over 25,000 lens enhancements that were selected. And then we have essential medical eye care savings. This is when the member goes in and they need additional CPT codes for claims such as pink eye, diabetes, diabetic retinopathy, dry eye, glaucoma, macular degeneration. And in most cases, the medical plan is primary for the coverage of these. But if the VSP provider is not participating in the medical plan, then they will bill VSP with a $20 copay. And that means that that's not hitting the member in out-of-pocket costs, that they're not having to pay for that. So that was 709 claims for a little over $148,000 in savings. And then the extra frame bonus. This is where VSP is offering get an extra 20 on featured frames and then an extra 40 on select featured frames. And your population saved almost $36,000 in out-of-pocket costs. And that was a little over $2,500 or 2,500 frames that they selected that received that discount. So nice big value there. When they go to that VSP provider, they can determine which of those frames are a featured frame because it'll have a little heart sticker on the lens. And so that kind of directs them to know this one is going to save them in out-of-pocket costs. And then the frame markup protection. This is our wholesale guarantee, and this was a savings of a little over $143,000. That was 651 frames for the basic and a little over 2,000 frames for the plus plan that had this guarantee. I'm going to go into this a little bit more in this next slide. You can see here what this wholesale frame guarantee is that with your $150 allowance, that wholesale frame guarantee is equivalent of $57 for the basic plan. And the $225 for the plus plan is $86 for the wholesale. So if they go in and say Dr. A sells that $57 wholesale price frame for $150, but Dr. B down the street sells that frame for $170, the member is going to have zero out of pocket because that wholesale amount is the equivalent. So in a case where the wholesale amount is greater than the 57 or the 86, and the retail price is greater than the 150 or the 225, then they will receive a discount of 20% off that overage. And so if they, my example here, if a basic plan went in and they had a $200 frame and the wholesale price was above that 57, as well as the retail price above the 150, they would have had only $40 out of pocket after that 20% discount. And on the plus plan, if it was a $300 frame and the wholesale was above the 86 and above that 225 retail, then they would have had only $60 out of pocket versus the 75. Any questions? I know this was something that was of great interest to you. Okay, great. Thank you. And then a little bit on member engagement and how we're going to work with PEB and OEB to promote what we're doing to promote member awareness on materials. So with PEB, we've put in a Spanish client-specific website along to match the English-speaking client-specific website as of January 2026. They can go to this website and they can click the Spanish site, or they can go directly to the Spanish site. So, we're really trying to promote this is an option for you if you are not English speaking. Member communications are available in Spanish for our open enrollment videos, our benefit summaries, the evidence of coverage, multiple flyers, and then at our last board meeting where we presented, you guys asked, if there were other languages available upon request, not for the client-specific website itself, but for materials. We do have many materials that can be translated into other languages. There's a multitude of languages. We would just need to know which ones you were interested in. There may be a slight cost depending upon the amount of languages that would be needed. And then we also have our BSP member services line and our TTY 711, where they can get assistance in 25 different languages. So we're really trying to meet the needs of everybody and communicate in the language that best suits them.
I just have a quick question, Valerie, if it's something that we could have for future board meetings, now that you've instituted this, whether you could provide tracking numbers through the website or through the materials that are being shared, what the usage is in Spanish, as well as what other languages come up, because it would be interesting to see if that goes up over time, if more people are utilizing, knowing that they can get the care in preferred languages.
So the tracking of the client-specific website and whether they're going to the English or to the Spanish, yes, we can provide that.
And I think additionally, I mean, I know on our end, for example, like you can track how many people call in or who request for other languages. If that's data, you'll be able to provide in the future too, now that that's an option.
I believe so. I will have to confirm on the requesting of materials in other languages, but I can definitely tell you we are tracking the utilization of the client-specific websites, and we will make that an action item on your question about requesting different languages.
Thank you.
Emily Wang?
Oh, yeah, thanks. Can you hear me?
Yes, I can.
Good. I've got the computer and I'm in the room. When you were saying that it costs to get it in other languages besides English and Spanish, who does it? Who's bearing that cost, or who does it cost?
So that would be a cost to the to PEB.
Oh, a cost to PEB. Okay.
For the translation. And it would really depend on what it was that we were doing, the intensity of it, things like that. For the most part, we try to bear the costs for materials and things of that nature. But when it comes to translation, we do have to look at that and determine what that cost impact would be.
Okay, thanks.
You're welcome. And then one of the things that we were working with the PEB staff is to promote an annual eye exam. And so This is an opportunity for us to increase healthy exam utilization by leveraging some of the existing programs that we have that will intentionally and strategically ways to focus on preventative care. So this would be a mailer that we would be sending out to both PEB and OEB members that have not had an eye exam in the last 12 months. This would be an encouragement to go in and schedule that appointment. And then we would also track this information. And our goal would be to increase healthy exam utilization by 1.5%. Currently, your exam utilization for employees is 44%, which is about 9% higher than our book of business. And then for dependents, it's 30%, which is only 1% higher than our book of business. But this is an area where we know that our doctors are looking for conditions that could be medical conditions such as diabetes, hypertension, high cholesterol. All of these things can be detected early in an eye exam. And so we really want to promote the utilization of this benefit. And then how we're going to do this and the timeline. So we've already presented this and we've already talked to the PEB and OEB staff. So that phase 1 is complete. Phase 2 is in process in that we have created a custom postcard and mailer, and that's being reviewed. And then phase 3 would be to send those out. Or part of phase 2 will be to send those out, and then members will make an appointment to receive services, hopefully in that phase 3, Q3 2026. Then phase 4 would be tracking that utilization on the members, but we will also track that utilization into Q1 of 2027. We'll look at that for, several over a extended time period because we know that people will follow up and be going in to receive services past that. Any questions? Okay, so then we'll jump into the rural network access. In the DSP is providing multiple solutions for that small percentage of just 2.7% of employees without access to one provider within 25 miles of their home zip code. That's the equivalent of about 875 employees, where you do have 97% that do meet that access requirement. The key challenges that we're experiencing with this is, that members have to travel typically in these zip codes for most services and access to healthcare. So we know that a lot of them are already used to doing that, but we'd like to provide options so that they don't have to. And if there is a provider, in many cases, they may not have available appointments because there's so many people that are trying to get in. And then providers in the area that are just not accepting insurance. We see that more and more in these rural healthcare deserts. When we look at the counties of where it is that there is not a provider, there is not access, or there's only one provider, we took both the PEB and the OEB members in that area because it's important that we have, a relatively large number in order for us to do a mobile clinic there. And so in Baker, there were about 400 member population, and the percentage without access is 99%. Curry County, 191, but 51% have access to one provider within 25 miles. Grant, no access for 241, as well as Harney, 250, no access. And last year we did a mobile clinic that was in Harney, but it was right on the border. And so it was available for both these populations. And then Coos County, which is where we're looking to do this again. This is the largest member population without access. And while the majority only 10% are without access. There's only one provider. And so we know that they are having a difficult time scheduling an appointment. And so we're looking to do a 4th mobile clinic in Coos County. And I have the timeline that goes into that. Or actually, we have 3 other solutions that are available. We have our access guarantee, and I'll go into that a little bit more in detail. We also have Iconic, which is our online retail website. And then we have the mobile clinics that VSP is sponsoring, 1 per year that can run anywhere from 2 to 3 days, and sending out notices for attendance. The access guarantee is for those members who do not have a provider within 25 miles of their home zip code, or cannot receive an appointment within 30 days of calling an in-network provider. They contact VSP customer service. They get a pre-approval for in-network benefits at an out-of-network location. The member pays the provider for the services after their eye appointment, and then they submit the claim to VSP for reimbursement up to the in-network claim reimbursement. So it's a great way in which we are able to provide service, even if it is that they have to go out of network. And then online shopping with Iconic. This is VSP's digital first retail website where members can shop with their benefits online. There were 895 claims, spending of a little over $126,000 in the last 12 months on Iconic. So this is being utilized. We cannot tell who exactly is utilizing this. So we can't tell if it's someone who's in, downtown Portland or in Coos County. But they can go online. They can do a virtual try-on of glasses. They can shop with their benefits online so that they can see what is their out-of-pocket costs. And then, so full integration with their benefits. They get all of the retail discounts and online on Iconic as they would with a VSP provider. And then we also have Visibly, which is where they can update their prescription if their prescription is out of date. So they can go online and they can upload their past prescription, and it will be reviewed by a licensed doctor, and they'll answer a few questions. And if they meet the qualifications, the prescription will be updated oftentimes within 24 hours, and then they can use that updated prescription to shop online.
Valerie, you have a question?
Yes.
This is Siobhan. I was just going to make the comment that I appreciate that VSP has continued with the mobile clinics. We had, as you know, a lot of access issues, particularly in Coos County, and we just haven't heard those complaints since the mobile clinics started. And also just glad to see that they're moving around the states and you're, partnering with OEB and getting a critical mass so that people can get the vision care they need.
Thank you so much. We appreciate that. Was there anybody else?
No. And we're looking at about 5 more minutes for you. I know our times are a little off, but we're trying to keep you within your time slot. Thank you.
Thank you. And this will be the last slide. And so for the mobile clinic, we have already been in discussions. We've done the research. We've done the planning for Q1, and then phase 2, we're looking to approval for the event dates and to secure a location. And then we will work back with On-Site Eyes, which is the vendor that does the mobile clinic for us. So our goal would be to contract with them. And then phase 3 would be the event promotion. We work in partnership with the OEB and PEBB staff to do that. We would then also secure a credentialed provider that would be the one giving the exams at the event. And then Q4, our intention is hopefully to be able to have the event the first weekend in October. We leave that kind of, the goal is October, but we leave that a little loose because we do need to secure a location as well as the provider. And so it's helpful to leave those dates a little flexible, but we look forward to be planning the rest of this with the team. Any questions?
What's it look like? Thank you, Valerie, very much. We appreciate it.
Thank you. Have a great rest of your day. Bye-bye.
To keep us on track, unfortunately, this room will be utilized at 1 o'clock, so we'll have to make sure we try to get through as much as we can today. Next is round 3 renewals. Looks like Emery will get you started there.
Okay, I'll get started. Andrew's actually going to be kind of leading through most of this renewals, but just wanted to say thanks, and we'll go through the agenda that's listed here. Andrew, you want to just take over?
Yeah, can everybody hear me okay?
Yes.
Okay, all right, thanks. Thanks, Emery. So I'll just make a couple of comments on this slide before we kick off and continue this conversation around 2027 renewals, specifically for dental, vision, life and disability, and some of your supplemental coverages. And so for the most part, we're excluding medical and pharmacy from today's discussion, although there are a couple of points where it'll sort of weave into the conversation. You know, obviously 1 week from today on 4/29, the board will convene to talk about the RFP results and potentially select an ASP for 2027. And so after that meeting, medical and pharmacy will be integrated into this 2020 conversation a little bit more holistically. And so here we've got our agenda here. Probably no surprises for board members. We'll do a quick update on the health equity effort that the committee has been putting into the renewals for 27. We'll do our sort of typical financial roll-up and take a look at the projected composite for 2027 with the asterisk that, you know, we're still working through the RFP on the medical and pharmacy side. We'll then continue our discussion in section 3 on dental and vision, life and disability with the standard, and then your supplemental renewals. We've got a couple of slides on medical and pharmacy plan design benchmarking. And so those are really intended to just sort of generate some discussion in a very preliminary sense with regards to potential plan designs for 2027. And then we'll talk about next steps. So if we want to proceed, yes, to this slide. Thanks so much. And so this is a continuation. I'll provide this update, although it's really the Health Equity Committee and all those members who participate in that work stream who are doing this work. But this is the topic that we've talked about over the last 2 months. And it's an update on the Health Equity Committee's focus point around accessibility with the 2027 renewals. And so language accessibility as well as ADA accessibility. You may have noticed that both VSP's deck that Valerie just went through, as well as this Mercer presentation, are based on the OHA approved accessible template. And so our presentations moving forward are going to have the look and feel of what you're seeing here. And it's really intended to just make this content a little bit more accessible. And so this is sort of our test run. I think this is the first board meeting where we've used these templates. And so you could see some slight tweaks, you know, over the next few months, but generally I think this is what they're going to look like. And so here we've got this table, which is showing your key vendor partners and then their status around language accessibility, as well as the ADA adherence accessibility piece, which is the bottom row. And so most of these are confirmed. We have had a lot of back and forth with BHS. BHS is your COBRA and self-pay administrator. And so these are in process. there is a potential for a slight pass-through cost for some of the Spanish translation. It's a relatively small cost, and so we would propose working through staff, PEB staff, with regards to that cost and getting it covered. And then Weight Watchers, there's another caveat there. You can see that they did confirm that the Spanish capabilities, however, the mobile app is on the roadmap, and the TBD for Spanish capabilities on the app. The ETA is TBD. Sorry for the acronym. So we'll follow up once we have a more specific milestone that they're working towards with regards to what date that functionality will be live. Any questions or comments? I'm going to pause and if not, I think we can proceed. And so now we'll sort of get into our normal content that we do in these renewal meetings, and I'll hand it over to Emery if you want to take us through this financial roll-up.
Andrew. So as Andrew mentioned, we are kind of not talking about the medical. We are just talking about dental, vision, and some of the disability and other ancillary programs. Similar to prior months, we're showing the dental rate changes there at the top. Based on the latest claims information we have, basically Delta Dental of Oregon is at 3.4% of a rate increase. So, it worked out that way in terms of the claims. And so the total projected premiums is just over 66 million. The Kaiser Dental and Willamette Dental, those preliminary rate increases are the same. Kaiser's at 3.4, Willamette's at 9.5, but there's going to be additional information talking about rates later on. VSP, based on the most recent claims experience, has kind of been fluctuating right around 0, positive, negative 0.1. It's right now at 0.1. And I think that's going to be essentially our final rate increase, assuming no plan design changes, and the total premium is about $12.5 million. ASI Flex, no rate changes, and that's about $501,000 based on what we have for projected. BHS is 3% increase to about 200,000, and then Weight Watchers, we show the cap there, although the cost on essentially a per participant basis potentially could drop 20%. Okay, so next slide, please. The composite rates. So down at the bottom, we have the updated composite rates based on what we would say is status quo medical. So those are, if the plan continued, added 3.4% to the admin, about 7% premium increase for Kaiser, and then just claims plus trend for the other medical plans, in addition to what you see up on the prior page for the dental and vision plans. So at the bottom, you can see it's $2,062.59 for the composite rate. That's about 8.7% increase. As everyone knows, limitation is 3.4%, and we're about $75 million above that limitation. This number will change based on, the RFP results on who's voted in. We will provide a preliminary update on the 29th. But currently it is at 8.7%. So it is significantly above the 3.4%. So as Andrew mentioned, talking about potential plan design changes, you might have to talk about that and reserves in order to get to the 3.4%. There is a little bit of good news on the composite rate. I think we can move to the next section. 27 renewals. Yeah, so life and disability. One of our other Mercer colleagues, Rich Furstenberg, presented some information about the renewals and for disability and life, and how there were some essentially reserves, in the premiums that Standard's holding to kind of cover for like unexpected fluctuations or high claims or just general situations. Standard came back discussions with Mercer on updated rates, and this is what you see right here. Basically, some of those reserves that were being held are being used to help bring down the cost, not only for the basic life, which is part of the composite rate. So you can see it actually went down to 11 cents per $1,000. So that's $1.10 for per employee for the life. And that's a decrease that's shown in the composite rate above. That total is a 31% change. You have some other basic life insurance rates that also potentially will decrease by about 30 or 37% that you can see there. And then the other portion, the optional life and voluntary AD&D and short-term disabilities, you can see the rates that are recommended or standard proposed based on some of the buy downs. These are, in many cases, bigger decreases than what were shown in last month. And so these would be directly, as part of the paycheck. If someone signs up for it, they'd be paying less as a result of these rates. So the optional life, well, generally they are based on age. You can see that, the decrease is about 37% for the employee and spouse. Retirees is about 20%. The child closed group, there's no one in there right now, but that's flat. AD&D is remaining flat, but then on the disability, short-term disability, you can see some decreases as well, some of the LTD programs. So there are potentially some savings to members if they are in these programs based on these rates that Standard has proposed. Any questions?
Just a reminder, only the basic life ends up in our composite, yeah?
Yes, that's correct. $10,000 benefit. Yeah, it is part of it, $1.10. Yeah. Would be $1.10 in this case, which is actually in the composite rate that I showed previously.
Thank you.
And Rep knows I did say, yeah, $75 million above the 3.4% limitation. Okay. Andrew, do we want to talk about potentially accepting, or do we want to hold off on making any decisions regarding these benefits until next month?
Yeah, we could. I guess we could pose that to board members. You, to the extent that you're feeling comfortable and sort of feel like the conversation has, been had and you're adequately informed, you certainly can vote on some of these benefits. And so if you want to approve this one, dental, vision, supplemental, that is something that we can do today. Or if you prefer, we can look to do it next month.
I just have a question just for perspective. Can you share, the percent that the dental makes up of the overall composite, just so that we have that perspective? Because, I am imagining the lion's share of that 75 million is about medical.
It is. Actually, if we want to go back a couple slides or 3 slides, I believe, back to the one where we showed the dental. One more.
And I guess, just for more perspective, for me,
One more, please.
if it doesn't have that much of an impact, dental overall, I'm more comfortable moving forward with that discussion today.
Yeah, so actually, Rose, one more slide down. Thank you. Okay, so you can see here, overall, the benefits we're talking about here is about $108 million in total. Dental is the bulk of it. So that's about close to $95 million. Your budget is $1.5 billion.
Yeah.
So dental is, a relatively small percentage. So 7% of or 8% of the overall composite. So it's not going to make a significant difference. Dental, Moda and Kaiser are both basically 3.4%. We'll show you something from Willamette where they offered a 3-year rate guarantee. So each year would increase by 3.4%, which is, at your limitation. And obviously vision's basically flat. So it, changes there will have a very minimal impact on really the overall composite. It might move things. There's a couple bigger plan design changes that you might not want to do, but could move it by a few million. But you, again, to Revnos's point, $75 million is the gap. So it's not going to make a huge.
Okay, that's helpful. Thank you.
And 75's a lot, right? It's not, that's
right.
It is. It is.
You say that's going to be updated.
Yeah, it is going to be updated, Revnos.
Is there a chance that it's going to come down?
Yeah. Pretty good chance, yeah.
Okay, good. Hopefully it's a lot.
I'll leave that up to your determination. Well, I think, there are certain things I can say about the RFP, and I'm not sure that's one of them I can say right now. Okay, all right, moving down a few slides. So in terms of the disability, I guess, Andrew, do we want to again see if the board wants to potentially vote on this or hold off, Chair?
Yeah.
Yeah, we could do that. And so, if we do, we're taking a vote on, is it just the disability for now, or would it be
Yes, it would be just the
just the
disability.
disability for now?
Yeah, and as that,
I know we're really short on time today, so if you do your presentation, we'll actually run out of time.
oh yeah.
So, just
So-
trying to remind everybody.
Okay, so do you want to just hold off then if we're gonna run out of time?
Yeah, I think it would be best, to continue to try to get through what you have. And then if there are any big questions, we can get those answered at the next meeting. I don't want to take a lot of time. Just like I said, if you finish your presentation to time, we're actually out of time
Okay, gotcha.
for anything else.
All right, gotcha. Okay, Andrew.
All right, thanks. Thanks, Emery. And yeah, that sounds good, Greg. And so I think at this point, if there are no other questions on this standard renewal and these rate actions, I think we can proceed. And for this section, I'm going to hand it over to Emily Rodman.
Yeah, hi everyone. Thank you. Thanks, Andrew. So in the interest of time, I'll try and get through these fairly quickly. A lot of these are items that we've already shared. So this first section is the dental renewal. And as Emery mentioned, due to some additional plan changes and considerations, we actually broke these out by each carrier. So first up, we have Delta Dental. And as Emery mentioned, they did come in at 3.4%. But we and their status quo, it did drop from 3.9 to 3.4, and then their admin is still at 725. And so this slide first shows you three that we have already shared, which is increasing the annual max and lifetime ortho max to 2,000, and then also adding that cone beam to class 1 services. And since all of these have a cost impact, Mercer is actually recommending to decline this. And just jump in if you have any questions. I'm just going to go through the slides here. So next slide. So these are two that we have also previously shared before. Pulp capping is to change it to a separate charge for a separate charge for pulp capping to a non-covered benefit, and this is to protect the member from being billed twice for something that should be included in the restoration. And then the next one is bone grafting, which is used to rebuild and strengthen that bone in preparation for an implant. Both of these have negligible impact, and so Mercer is recommending to accept these changes. Next slide. So these next few slides, I'm actually going to turn it over to Trinity Cleveland, who is a registered dental hygienist here at Mercer, and she's part of the dental CEO. She's going to kind of do a deeper dive and an overview of this re-cement rebond frequency change that we've been discussing. So Trinity, I'll turn it over to you.
Thanks, Emily. Hi guys, thanks for having us on today. Just wanted to talk a little bit about the re-cement and rebond frequency questions that have come up. I know this has been kind of a topic that's been bounced around a couple of times. So currently the benefit for re-cementing and rebonding the crowns, onlays, and veneers, as well as implant and or implant abutment supported restorations, was limited to once every 12 months. So now we're considering whether that should change to once per lifetime per restoration. And so really what this looks like is that within the first 6 months of having the initial restoration placed, whether it's a crown or onlay or veneer or whatever it is, that during that 6-month time, the provider basically offers like a warranty, if you will, on re-cementing it. So there's no cost to the member at all for that. And that's pretty standard across the board. And then after that 6 months, the first time that one of these needs to be re-cemented would be covered as part of this new lifetime lifetime re-cement or rebond. Or if they end up having to have the restoration replaced, then it would move. Similarly, it's going to restart that. So it's not per tooth, but it's per restoration. So anything that would happen in any re-cements that needed to happen after that, the first covered service would be the member's responsibility. Now they can submit for an appeal or request an exception to the rule by submitting additional narrative with the claim, as for like a reasoning for why it came off and, whatever that may be, and have consideration for that coverage. Delta Dental is basically recommending this because it aligns with their more national policies and supports clinical standards of care. And excuse me, it's basically aimed to promoting the durability, clinically appropriate treatment, and address better the root cause for a restoration to continually need to be re-cemented. That's just not something that we would expect to happen regularly. Are there any questions there?
Yeah, I think last time we had this conversation, I think there was an idea that a normal cementing would last some number of years, like 15.
Yeah.
And so the presumption being, well, 15 years later, they buy a new one, as opposed to time,
Right. Yeah, that's correct. And actually, I can give you a personal experience with that. I have an implant crown that was cemented in 2001, I believe, with a temporary cement that has never come off. So they just, and it was cemented temporarily, and it won't come off. So that's on a molar tooth that's, used very heavily. So yeah, the likelihood of this happening is really very low. I think Moda gave some numbers around what it looks like, as far as the utilization. We can look at that on the next slide. So, okay, so we spoke about the exceptions and appeals and again, what that looks like. And so you see here from the utilization and the impact, this is going to be a very low impact to the members. And so if you see like from 2022 to present, 13 members would have been denied their claim. That's, over 3.5 years. It's very low, very, very unlikely that this would happen. So some of the concerns that the board has expressed previously is about, members' cost. Again, it is uncommon if something is going on where a crown or, restoration needs to be re-cemented, it usually happens within that first 6-month time. Usually it's because there's been some kind of contamination of the cement or the bonding that they're using. And by contamination, I don't want to worry people, I shouldn't have said that word, but like if a little bit of water gets into it, is that could cause it to come off. And so it would have to be re-cemented. You're going to know that right away, definitely within the 6 months. As far as, durability, again, these are it's just uncommon to have, if there's an issue with durability, it really applies to, again, to the restoration. If the restoration overall is not durable, then it needs to be redone, and re-cementing it over and over again is not going to provide any benefit to that member.
You have a question?
Yeah, I mean, it was, just the way it seems is like what the provider doesn't want to pay for is if somebody has a habit that causes the cementing to become undone versus like if there's another trauma, they would be able to get a exception. Traumas happen, like.
Sure, and with a trauma-related kind of situation, honestly, a lot of times you're going to need a new restoration. So that would reset that time frame also. And as far as like, patient habits, like tooth grinding and stuff like that, well, that could be prevented if they're wearing a night guard, for instance, which is when grinding usually happens. Or, high stress jobs, I wear mine from time to time when I'm thinking too much and I wear it while I'm working. So there's ways that they can prevent that. And really I think part of the rationale for changing this benefit is to encourage better behaviors.
Thank you.
Thank you.
Any other questions?
I see none.
I will give it back to Emily.
Thank you. Okay, so the next slide is just the same slide that we've presented before. And this just shows that based on the limited number of members impacted and the potential to steer members towards more appropriate long treatment options, that Mercer does recommend accepting this change. Okay, moving on to the next slide. So since Moto was coming in at 3.9 after round 2, we did go back to them and asked for for them to provide some plan design changes that could help with savings and the overall renewal. So this slide shows 3 options of plan adjustments that would reduce cost. Obviously, as Emery mentioned, it's now coming in at 3.4, but we still thought it was important to share these options with you. So the first option there is to increase co-insurance from 10% to 15% for the preventative service when members see an out-of-network provider on the PPO plan. And just as a refresher, the PPO plan is what's called an active PPO. So members have to see a PPO provider to get that like higher level of in-network benefits. They can see a premier provider and still be protected by the from balanced billing, but in order to get that higher level of benefits, they need to see that PPO provider. And so this would be a savings of $335,000. And then the next one is the same type, but it's increasing it from 10% to 20%. So that would create a savings of $670,000. And then that third one down there is actually to eliminate the Premier plan altogether and move members who are on the Premier plan to that PPO plan. And as you can see, there's a 5% savings or $3.1 million. As you may know, PEBB has 2 dental plans available to them. They have a PPO plan and then the Premier plan. And the differences between those plans are that the PPO plan has an incentive level for Class 2 benefits. So members start out at 20% and then in year 1, and then moving to 10% in year 2 and 0% in year 3 for those Class 2 services, as long as they continue to see a dentist every year. Whereas the Premier plan, you just stay at that 20% co-insurance level for the Class 2 benefits. And then, as I mentioned before, on that PPO plan, you do have to see the PPO dentist in order to get that higher level of benefits. Currently, there's around 58,500 members on that Premier plan, and there is about 44,000 of those members who are currently seeing a Premier provider only. So those members would need to switch to a PPO provider to receive that higher level of benefits. And was there a question? Sorry. No, okay. And like I mentioned, you are still if you see a premier provider, you're still protected by the balance billing. But you would, in order to get that higher level of benefits and and not have that co-insurance, the 10% co-insurance, they would need to see that PPO provider. We did confirm that there, of those members, 99.3% of them do have a PPO provider within 3 miles of their house. So they do have really good access. And then MODA also agreed that they would do a PPO provider campaign to those members and reach out and let them know about the change and how they can find a PPO provider in their area. And because this was new from last month, we just wanted to share this and kind of hear your thoughts. And Mercer has not provided a recommendation at this time, but we just kind of wanted to float this idea to you guys and get your reaction. Any questions or comments? Okay, moving on to the next slide. Oh, Kimberly?
So just if I understand you correctly, so there are people that probably were in the PPO plan that they were going to a provider they wanted to go to. They didn't even realize they weren't going to a provider that was needed to have the benefit of the plan they picked. Am I getting that right?
So currently, just looking at that Premier only plan, those members, that 58,000 members, those members are on the Premier only plan. And so of those members, there's 44,000 that are seeing a Premier only provider. So the rest of those people are currently seeing a provider that is PPO. So it would be no disruption to those members.
Okay, gotcha.
Yeah.
Thank you.
Mm-hmm.
It would disrupt 44,000.
It would be 4,000.
Yeah.
There are 14,000 who might get better benefits in the PPO plan because of seeing a PPO provider.
Yeah. So PPO providers take lower fees, which is why there would be such a high savings for that change.
I don't know. It's a little bit more obviously blunt force, but more savings in this case if you feel it's necessary.
Like if they would start at 20%. PPO.
That could be probably negotiated or discussed.
Yeah. So the class 1 is 0% co-insurance, and then the out of network would be 10%. And then, as I mentioned, that class 2 is that incentive plan where it starts at 20 and then after year 3 it's at 0. But everything else is the same between those two plans.
So Emily, this is sort of like essentially narrowing the network, right? There are a couple
Right,
of those little
yeah.
incentive plan design differences, but really it's about narrowing the network, which is going to be disruptive to a decent chunk of folks, right? And generally members don't love changing their dentist, and so that is something to keep in mind. But there are significant savings related to this, and given the position of the composite, we wanted to bring it forward for discussion. But like Emily said at the outset, we're not necessarily recommending any of these 3 changes.
And I'm also just curious, what's the premium difference? Like, I'm assuming there's a premium difference.
Well, there is a premium difference. It's based on the percentage that your medical plan is. So it's not, basically you're paying, let's just say 5% of $71 for an employee only, or 5% of $77 for employee only.
Oh, so
That is
negligible.
negligible.
Yeah, okay, that's helpful.
Okay, so moving on to these are all 3 that we've shared before. So these are just those admin changes, not benefit changes. So adding teledentistry, adding clarification to the domestic partnership affidavit language, and then adding language to the handbook to state that a pulpotomy in conjunction with a root canal is not covered. Again, these are negligible and no cost impact. So Mercer is recommending to accept these changes. Okay, next slide. So Kaiser Dental, no changes from last month. Renewal still at 3.4. No new plan design changes being recommended. And so Mercer's recommendation is to decline the annual max increase due to its cost impact. Next slide. So yes, as Emery mentioned, Willamette Dental was coming in at 9.5. So we did ask Willamette to come up with some cost-saving options and plan design changes to reduce that rate. They provided us with the following options. Each have various level of savings to lower that rate increase. Option 1 has a target increase of 3.4 and includes increasing the fee from 10 to 25 for general ortho visits, increasing root planing copay from 0 to 45, routine extractions from 0 to 20, and increasing the surgical extraction from 40 to 85 copay. And this would be a savings of $800,000. Option 2 is a target increase of 6.45, and this would just be increasing that general ortho visit fee from $10 to $20. And then option 3 is target increase of 7.98, and that would also be increasing that general ortho visit from 10 to 15, and that would be a savings of $200,000. And then, as Emery mentioned before, there is this fourth option, not a plan change, but that would be to do no plan changes, and Willamette has agreed that they would offer a 3.4 step increase for the next 3 years, which would be an increase of $517,000 or $100,000 increase per year, and a savings of almost $1 million for 2027. So with that, it is Mercer's recommendation to accept option 4.
So it would not be the 9.5, it would just be 3.4 over the next 3 years.
Yeah.
Correct. Yep.
9.5 and those 3 fours.
Yeah.
Thank you.
Yeah, it's 3.4 for this year, next year, and the year following.
Yeah.
Yeah, so cost certainty.
Right, yeah, we have,
But then again, you are increasing every year, so there's no chance that maybe it would have been flat, but it's just 3.4%.
And like, in terms of numbers, do we have, I felt that the Willamette dental plan was less expensive than the other two. That not true. And I guess, like, I feel like as a board, we've had more variation between our dental plans than we've had between the
I
medical.
think the last couple of years, Willamette has been at 0, haven't they, Emery?
I'd have to double check that. I don't remember. I'll try to open up like a file that we have. I know there has been years where it's been 0.
They've been pretty low the last couple of years, and I know because I remember Sean asking, they've been at 0 for several years, and now all of a sudden, the last slide we saw was they want 9.5. Why didn't they do this, the last couple of years? I remember that question from you specifically. And so this is, I think, maybe a way for them to continue and not give us that high rate all at once. And then, next year it might be flat, but it might also be 2 or 3% next year. We don't know. Where this way we're guaranteed for 3 years that they're not going to go above what we've asked everyone else to be at.
Yeah. Oh, so Siobhan, your question was in regards to just the premiums. How do they compare to the other plans?
Yeah, and then I'd also be curious to know how they compare to the other plans on these option 1, 2, 3, 2. I just don't have a good sense of what
There's such a different plan design because Willamette is a copay versus the co-insurance and an annual max.
Right.
So,
it's hard to compare.
It is hard to compare. I mean, the $10 fee for visiting the office, I mean, depending on what you do for the other ones, right? It's preventive is free. Why you're paying what 20%, let's just say, of a few $100s, right? So it is definitely different in that case. And yeah, let me see. Hopefully,
I mean, I know we're not making decisions today. I was just curious.
Yeah. So Willamette is actually kind of close to Delta as the PPO in terms of rates. They've had some increases from from year to year. So it hasn't been flat for a little while.
Okay.
Yeah, it was I think 2024 maybe when it was flat, and then probably.
And I would have been thinking about no increases to admin fees as opposed to increases to the insurance itself. That might have been where I was.
Yeah, so Willamette,
Yeah.
because it's a fully insured, so they give you they do give us like a percentage for admin. And so there's a percentage we haven't really looked at. We've looked at in total.
Okay. Thank you.
Generally speaking, what Willamette has a low cost delivery philosophy and mechanism, but they are selected against, right? There are members who will elect that plan when they have orthodontia needs, get that ortho coverage and those services and get that need met, and then potentially migrate out of that plan. So that is something that is a dynamic that exists. It doesn't explain the 9.5% increase for 2027 because that dynamic, has been in place. But I just wanted to call that out since we were talking about the differential in the rates between Willamette and Delta.
Okay, if there's no more questions on this, I'll go ahead and move to vision, which is next couple slides here. So no new information from last month. There's VSP is currently in a year two of a 4-year rate guarantee. Admin rate is $1.15. And then, as Emery mentioned, the status quo increase is 0.1%. All of these options that we've discussed either create a cost or add some member disruption. So it's still Mercer's recommendation to decline these changes and renew as is. And just a quick reminder, the changes were to add a frame allowance on the basic plan and adding the high index lenses to a $20 copay on the plus plan. And then the next slide is just carried over an additional slide, and that is the option to move everybody to the choice network, which we discussed last month. Okay, next up is the supplemental programs. If you can go a couple slides, there you go. Thank you. So again, no changes from last month. The first one on the top there is ASI Flex. No proposed changes or rate increases. And then the one down below that table is the Benefit Help Solutions, the COBRA and Retiree Premium Administration. And so there's no proposed changes, but there is a 3% increase for that one. And Mercer is recommending to accept both of these renewals as is. Okay, and last up is Weight Watchers. And so Weight Watchers did come back from round 2, lowering the program fee from $32 to $30 for that P. I'll just say per engaged member per month, the PEMPM. It's a mouthful. And then the program cap fee is still $1,379,000. And then they do have a non-billing clause for those inactive members, which means that PEBB is not being charged for members who are not using the program for 1 month. And so engagement, just as a reminder, is logging into the app or website or attending a virtual or in-person website or workshop. And so Mercer is also recommending to accept this renewal as it's listed here. Any questions before I turn it back over to Andrew? All right, well, thank you, everybody. Andrew, I will let you take over the design benchmarking, plan design.
Okay, sounds good. Thanks, Emily. So I just want to do a quick time check. I think we've got about 4 slides of content and then next steps. Greg, do you want us to just proceed? I know we got a hard stop time.
Yeah, we can pull the, what we're gonna try to do is we're gonna end up pulling some of the work group updates. So we'll try to make up some time there, but yeah, just, I think, continue on.
Okay, all right, sounds good. Yeah, and we may only need 10 or so more minutes for this presentation, so I think we're doing good. Yeah, so if we could just hold on this slide for a minute, Rose, I'll just make a couple of comments to just sort of set the stage. And so we talked about the budget gap of $75 million on the composite, but it sort of comes with some asterisks, right? That's just based on projecting current claims and admin fees and that sort of thing. But we know there's this RFP that's been happening and is reaching its conclusion here shortly. And so with the RFP, we do expect that there are going to be some significant savings related to that RFP, but not enough to completely close the $75 million gap. And so the intent of these slides here that we're going to be getting into is really to hear from you all and get a reaction and start talking about potentially some plan design changes on medical and pharmacy. And so the way that we're going to show these slides once we get into them is we're going to show PEBB's plan design alongside a couple of industry peer groups for comparison purposes. And so there's lots of different categories of savings that we look for when we're doing this annual process together and trying to achieve 3.4%, right? Like we negotiate with your carriers, either premium or admin fee, sort of a short-term strategy. We do things like this RFP, which is a long-term strategy. We try to achieve efficiencies through the plan design, which could either be short-term or long-term strategy, right? And then we've got plan design and we've got reserves. Plan design is typically the last savings lever that we look at, right? For kind of obvious reasons, right? Like affordability is one of PEBB's core values. And so it is not easy to talk about plan design change. But nonetheless, there are valid times to look at it. And so again, what we're going to show you here in these next few slides are really just to generate discussion. We're not making any recommendations. We're not showing you scenarios to get to 3.4%. It's more a start of the conversation. And so as we move through these next subsequent monthly board meetings, we'll get into more specifics, of course. But when you think about periodically indexing the fixed fee components of plan design, so like think about like a deductible or a copay or out-of-pocket maximum, to the extent that you hold those fixed fee components static from year to year to year, the plan does get richer, which is not necessarily a bad thing. That's another one of PEBB's values, right? Is to offer rich benefits to your membership, and that's a big part of the value prop of working for the state. But nonetheless, these plans get richer every year, and so potentially making some of those adjustments could be part of what we talk about in scenarios once we get there. But again, this is very preliminary. And so with that said, I guess thanks for bearing with me on that preamble. Let's jump to the next slide and look at how your statewide plan design compares against these industry cuts. And so just get you oriented real quick. You can see PEBB data there that we've highlighted in that yellow box. This is your 2026 plan design information, and what we're comparing it to are 2025 benchmarks. And so keep that in mind. If we were, and that's surely a timing thing, right? This is our latest data from our national survey that we compile annually is 2025 data. And so to the extent that any respondents to that survey who fall into one of these peer groups may changes in 2026, like likely these would have gone up, right? So like the deductible would not have gone down from 25 to 26 for state governments, for example. And so probably no surprise here to see that PEBB's statewide plan, and this is your broad PPO, right? This is your least rich medical plan. Is still significantly richer from these peer groups in a number of ways. And so if you think about the deductible, the top 2 rows, you can see $250, $750 for individual and family tiers. versus state government is 630 and over 1,000. And then that group on the far right, it's large employers. So employers with 20,000 plus employees. And so that's sort of casting a wide net, right? Like there's probably a lot of diversity in terms of respondents within that peer group, but it can be informative nonetheless, just to give you a sense for how these PEB plans are comparing. Out-of-pocket maximum and just stop me if there's a question. It's a little bit hard for me to see the conference room, but Emery, I just jump in and stop me if there's a question. Out-of-pocket max is also quite a bit richer. You can see there, this would be the third and fourth rows of the table. And so if you kind of just read left to right, you can see how those compare. And the same is true for PCP and specialist. The drugs are actually kind of in line. So your tiered copays for pharmacy are pretty close in line with these peer groups. And so again, if you think about, what we might be talking about in 1 month or 2 months or whatever, and we'll get you sort of oriented to the timeline here in a couple slides on next steps. Part of those scenarios might include things like a slight indexing of the deductible or the out-of-pocket maximum, that sort of thing. I'm gonna pause here. We do have a couple more slides, which will also go into some of the managed care plans as well, and just give you a sense for how those compare. And I'll make some comments, but I want to pause and see how folks are feeling, or if there are any concerns anyone wants to raise at this point.
I just have a couple questions. So when we're looking at statewide medical, that's our current Providence plan, right?
Yeah.
And what we don't know in this room is like what the current statewide medical plan is that we're going to be looking at in the RFP for its design, or is it designed just like this?
It's basically designed like this. Yeah.
That's just helpful to know.
Yeah. I mean, plan designs, as we ask for them to meet or exceed, and so.
Okay, so they're either at that or they exceed, and so then comparing.
So you're
the statewide to the MODA.
Yeah, it's the compare.
It will be comparable to what we'll see in the RFP.
Yes.
So if we're looking at differentiating anything, it would be statewide and MODA would be the two. Okay.
Yeah, you can work off with that. Yes.
Okay. Thank you.
Web notes?
Well, a couple of thoughts come to mind. One is, do we all want to do a mix of, do we want to do it all with plan design? Do we want to do a mix of this and reserves? I feel like we try really hard to be efficient, and I just don't know how you're going to get $75 million worth of efficiencies, but maybe that's a thing. I kind of have the same question that Siobhan has, like if we're transitioning to another carrier, can they do better? And then sort of also wondering out loud, if we bite the bullet and make some hard choices that will be unpopular, can we sort of ride them for a while? Like, okay, this will keep us kind of solvent-ish in the 3.4% zone for, let's say, 2 biennium, which would feel very amazing to this politician.
Yeah. So your first question around the efficiencies, I agree. We at this point do not think that efficiencies will cover the entire $75 million gap. Obviously, we have this RFP, and the RFP is not just about negotiating administrative fees. There are also efficiencies that are sort of interwoven into that analysis. And so that will be baked into the savings related to the RFP that are going to reduce the 75 million, but not get it all the way there. I don't know, Emery, maybe I could kick it over to you to answer the second question around, if we index plan design components, is that a 1-year savings, or can we think about that in a way that we can sort of get credit over the course of 2 biennium, for example?
So, there's been some plan design changes. I can't remember when the last time we did. It was like, I don't know, 6-7 years ago. something like that. I don't know, Sean, if you remember, you were part of the discussion, but they were to like essentially increase out-of-pocket max for a statewide plan, right? Prior to that, I think the big plan design changes were back in 2011, and those deductibles, while there was complaint, it definitely impacted the utilization quite a bit. And that a lot of reserves are built up as a result of that. So to your point, Rep knows there may be some additional efficiencies from slightly bigger plan design changes because people, actually take notice of it and they may impact how they utilize services for a little while. But obviously there is some pain associated with it because members are picking up more of the cost.
Right.
But Garner was put in. Garner's hopefully going to reduce the trend. So make it easier, right? For as people use it more, they potentially could use better, lower cost providers, and that helps with the trend. And that's part of the efficiencies we're hoping for. We'll see how that works out in this first year. But a lot of it's macro, and 3.4% is a fixed, and with healthcare, and the health, the trend committee, right? They had to change what the trend was too. So, there's definitely some macro considerations that might make it a little bit difficult to achieve that, I don't know, nirvana that you're hoping for from some of these plan design changes. But, I think there could be some additional advantages from making some plan design changes due to I don't know, better awareness of what you're spending.
Emery, are you aware of any other state government programs that are held to 3.4% by law?
I'll have to get back to you on that. I think there are, or not 3.4%, but I think there are some capped increases.
It would be good to know what the other caps are,
Yeah, we can do some research into that.
But when we don't hold to that 3.4, then the cost goes up, and then some other part of government's got to figure out how to cover it. So
I understand, but medical inflation's not the regular inflation.
I understand. We've had a good ride with that number. I'm not sure we can keep it.
The difficult part is when you're under 3.4%, like PEBB was a couple of years, and there's no banking that.
We can't average it together. That makes it.
I know. Oh yeah, I'm well aware of that.
We've had a good ride,
Yeah, we have. I agree with you. We've had a good ride. I mean, not other parts of our medical system have too. I do need to go to another meeting. So this is all going to get vetted next week.
Next month, yeah.
Next month.
Oh, next month. Okay.
Oh, in the RFP.
Yeah.
RFP, yes, next week.
So
Yeah.
So in terms
Okay.
of
I'm planning on coming.
all right, we'll see you
Thanks,
there.
everyone.
Thank you.
Thanks, Ripnos.
Have a great day.
Okay. Yeah.
Okay.
Was there a question in the conference room?
No, I think we're all ready to put next
Okay.
slide.
Okay. All right. Sounds good. So let's jump ahead to the next slide. And so now we're looking at MODA. This is a similar story in terms of comparison to benchmark. But one thing that I want to call out is that we're looking at the same benchmarks, right? And so the MODA plan is a managed care plan, unlike the broad statewide PPO. And so it's an imperfect comparison, but hopefully it's informative nonetheless. And so the deductibles and the out-of-pocket maximums are similarly a lot richer than the peer groups. The deductibles and out-of-pocket maximum actually are the same as the statewide PPO. But the PCP copay, specialist copay, inpatient stays, these are all richer than the statewide PPO. And so that's intentional, right? And so to the extent that we look at plan design changes, we really can't look at them in one plan without considering the entire ecosystem of medical and pharmacy plans, to make sure that, unless the board, I suppose, takes a different philosophy, but this plan richness spread is an intentional strategy, right? This is a managed care plan. We want to encourage folks to participate in this plan, for their own improved health outcomes and for, reduce costs from the plan itself. And so again, to the extent that we show you scenarios with indexing of certain plan design provisions, we can't do it in a vacuum with one plan. We kind of need to think about the spread between the plans. And that's before even considering, the very sort of realistic concern and dynamic around achieving a low-cost plan for purposes of contributions. That's a part of that too. But the differential is really rooted in the fact that there's a philosophy around these managed care plans and how do we incent folks into those plans if they have them available. And so on the next slide is Kaiser, which, is, I think we can just flip there and then I'll pause for questions. Similar, right? This is another managed plan. Maintaining parity between managed plans to the extent that we can is probably a worthy goal. And considering any plan design changes for Kaiser, as it relates to sitting in the same context as the broad PPO and all of that, it all needs to sort of be thought of together. Kaiser has the same deductible and I think a slightly different out-of-pocket maximum, but very similar. And then the PCP and specialist copays are different from the MODA plan today.
And Andrew, I was just commenting because we've had this conversation many times on the board. The managed plans, which include both Kaiser plans and the MODA plan, are all supposed to incentivize the better health outcomes at the end of the day. So that's the rationale for having them be priced in a way that they also are more affordable because people have narrower networks when they go into those plans, or Kaiser's a closed system, or MODA has a managed network on the that plan.
Yes.
Yeah, absolutely. Yep. Agree with that.
Kaiser, obviously with, the closed system, it is a different network. This some of the things I think we've done for choice and, the MODA plans is to try to create better efficiencies, right? It's not just plan design. It's like, what can you do to drive members to better care and be more efficient? And definitely try to keep that up, right? And fortunately, we can try to look for more, but it's difficult to get huge savings. Hopefully we can get some through Garner, but right now with the deficit the way it is.
And with MODA and then the finishing out of Kaiser, it's based on claims because they're self-insured. And just in terms of the cost that we're seeing for the increases.
Yeah, so Kaiser, as a health system, their trends get impacted a little bit sooner. And so that was showing up in some of their costs like a couple of years ago, right? Like where their rates were significantly higher. And that's because they were feeling the impact of labor coming out of COVID, had the nurses and stuff like that, and that impacted their overall revenue, and so that impacted it. MODA with the claims, the contracts are kind of being negotiated over time, and those are going up. And it's the costs are going up. And when we talk about status quo being like an 8.7% increase, that is because the claims are high. But it's also part because there was buy downs. And so that's baked into it as well. I don't think you're trending significantly higher than everyone else. I think Mercer has seen trends 10% plus for a lot of plans. I think without the buy downs, you'd probably be what was the buy down last year? It's like 20, 30 million, somewhere in that ballpark. Yeah. Because you bought down the low cost plans and some other usage. So of the deficit, that's the bill coming due. So you're actually not that bad if you don't consider the buy downs.
Well, I just want to say as we're discussing these kinds of adjustments to plan design, I don't think any of us are inclined to do so, but just for the sake of the record, this does not mean that we stop looking for efficiencies. I mean, that is really what the board's strength has been, with the various groups, innovation work group, CIO, everything, just pressing forward in kind of all directions for various innovations, occasionally leading to legislation. That kind of work, will need to continue because, as you say, most of the medical system is just on some kind of free fall into the abyss at this point as far as inflation. So even with adjustments, like we still need to press forward. And I really do believe that we still have room for new innovations that can really bend the curve. Like, for example, a lot of these costs, we haven't talked about this much. A lot of these costs really do have to do with labor. It has to do with holding on to a workforce that's lean. Heavy turnover. And that has a lot to do with provider satisfaction. And we haven't really dug into that. Like, what is that? And there are things that could be done that adjust provider satisfaction. That's not just the simple answer of just throw more money at them. There's that, but there's other things. So there's just all kinds of things that we can keep going. So I just want to say that, like, we'll keep going. And, there's the short term crisis.
May I ask? So, AI. I heard Sean say provider satisfaction and the administrative burden questions are from all of the angles, right? AI is a big player. Are we proactively approaching those sort of big frame shifting, paradigm shifting vector pressures, proactively approaching those so that we're building them in? Are we seeing them from our vendors that they're talking about what the impacts are and how they are using them to improve the trajectories of the challenge against these challenges?
Yeah, we're definitely talking about it. That's a huge concern. I think we expect that's going to be a big part of the next legislative session. And there's going to be a battle there, I'm sure. But
the innovation work group hasn't tackled it directly yet. I think there will be a few things coming out of the innovation work group that will be interesting.
Okay.
But it's not that yet. So that could be a future year. And yeah, so I don't know what you're hearing from the vendor side, but as far as integrating it into a deliberate strategy, I don't think we're quite there yet.
It is being used on both sides. I think
Makes sense.
from every side, I think if you listen in the OLEP conversation, part of the, and Garner has said, part of the trend increases because of AI.
More efficient
coding for,
That's
for
other
bills.
More efficient coding.
Yeah, putting more.
Means different things. to
Yeah, more
different-
more diagnosis
Highest
codes
cost.
going into your codes for the bills. And so it becomes a little bit higher cost in that case.
Okay.
So that's part of it. And then there's
Wow.
Insurance companies using it to look for ways of abuse and try to bring down the codes. So it's a constant battle on all ends. That said, it's additional cost, additional administrative, burdens and stuff like that. Healthcare is not. There's a lot of administration in healthcare.
Coding to efficiency, but yeah, I think upcoding's a better descriptor.
depending on the lens.
That very much depending on
That's
the
right.
rates. Yeah.
That's right.
There was a report out on it the other day that someone had sent me, and it's about AI speeds up prior authorization coding while driving higher costs for health systems.
That sounds like it's, pretty in line. But that's a big topic.
Yeah. But AI is probably gonna cost, but, you know, because it'll be, the system will be pushing it both ways. We'll see.
We'll see.
Anyway,
It ease the burden for providers
that may
in
be,
terms of documentation. I'm thinking of my brethren in primary care, right? How can it be used to make providers' lives
yeah. That could
better and let them spend more of their doctor education doing care and less doing the administrative stuff, just as an example.
Yeah.
Andrew?
Okay, are we good? Proceed. We've got one more slide on dental. If we could do the next slide, please, Rose. Dental plan design change. This is pretty high level. And actually, I mean, your current plan designs are pretty closely aligned, at least looking at these high level, sort of most impactful provisions within the dental plan. So you can see deductible is right in line. Annual plan maximum is actually a little bit low. This is one that we've talked about over recent years. Obviously, to increase it would be an added cost. And so, when I think about having this preliminary discussion around potential plan design changes, I don't know that dental is the first place that my mind goes to. We did show you when Emily was going through her slides that the adjustments to like out-of-network co-insurance for dental. But in the grand scheme of trying to solve for 75 million, wringing out $600,000 in savings, and if we think that we're going to incent folks away from those out-of-network providers into in-network, then maybe it's a worthy effort. But anyways, when I think about the number that we're trying to solve for, this is not. I don't think that dental is really where we're going to get it. The ortho max on the bottom row there is kind of in line, and furthermore, eligibility is such that it's not just for children. Some plan sponsors will set up ortho so that you're only eligible if you are, under 18. That's not the case for the PEBB plans, which is a nice benefit. And then, with Kaiser and Willamette, those are actually copays. Or Willamette is actually. I'm not sure about Kaiser, but that is a copay for Willamette. And so in that instance, the member would pay the copay, and then they would receive, as much orthodontic coverage as that individual member needed.
That Andrew, I mean, it just comes back to the information you were sharing when you're looking at the premium plan for Delta versus the PPO plan for Delta, and it just feels hard in a year that there's been such an incredible amount of struggle for members with collective health and Providence to have like 44,000 people also have to deal with their dental. So.
Yeah, I think that's right on. Yep.
That number right.
Yep, that type of sort of disruption and abrasion is different than, a copay going from $10 to $15, right? Like trying to find a new provider is a different issue to grapple with. And I mean, not to downplay the importance of affordability. Of course, that's important, but like you said, folks are disrupted with their providers that they maybe have had relationships with for many years, related to this Providence Health, collective health, ongoing issue that we've been working through. So yeah, I think that's a good observation.
Oh, I was just like, I'm guessing off the top of your head, how many members are covered. When we said 44,000 for the Delta, how many people are covered in Providence overall?
In terms of members, it's like 80,000.
More lives.
No, it's 80,000 members. It's like 33,000.
Oh, it's 80,000 members,
Yeah.
33, yeah, okay, that's helpful. That makes sense.
Okay, I think if we're good, we can jump 2 slides ahead to our final slide here in this presentation, which is the next steps. This is a little bit of a moving target. This is, I would call maybe a preliminary recommendation from Mercer is the right way to describe it. And so it's a little bit of a moving target because there are activities that are going to happen after the 429 meeting, which is 1 week from today, roughly. During that meeting, the board will determine what actions to take related to the RFP. And then negotiations and some other operational issues will ensue after that that could potentially influence the composite. But again, not to the extent of influencing it to $75 million. And so the way that we're thinking about this at this time is to talk with you in May around this sort of how do we achieve 3.4% conversation that we're kind of having today in a preliminary sense, and then potentially come back with final decisions in June. You know, it's hard for me to say if that's optimistic. You know, there's a lot of moving pieces. Plan design change requires a lot of discussion. And so are we going to be at a point where the board's comfortable to make decisions in June? I don't know. But I think, Ali, correct me if I'm wrong, but I think in some years we've had a July meeting or perhaps even a sort of off cadence, one-off type meeting that's not a third Tuesday where needed. Am I remembering that correctly, Ali?
Yeah, the board generally doesn't meet in June, but this year's obviously a little bit different. So we need to have that discussion with the board, you know, at some point, whether they want to have a month off but as you said, there's a lot of balls in the air with the RFP, so it kind of need to let it play out a little bit first.
Yeah. Okay. Thanks for that. Yeah. It's June that we're usually off. Okay. So any questions from board members or any other comments from Mercer staff with regards to what's to come? Given that we're in this kind of fluid environment with all these big projects and issues happening in the midst of trying to solve for achieving 3.4% in the upcoming plan year, and it's a little bit of a more fluid than prior years. Maybe that's a good way to put it, but I'll pause and see what comments and questions folks have.
Looks like we're good in here. I don't see anyone really.
I don't see anyone. Is there anyone on the line? No, it looks good, Andrew. Thank you.
Okay, great. Well, yeah, so that wraps it on round 3. And so thank you all for participating today. And yeah, next month we will do it again. At that time, perhaps the board will be ready to vote on some of the non-medical and pharmacy renewals. And so we will craft the deck in such a way to try to queue that up to make it as easy as possible for you all. But yeah, thanks again.
I think that would be perfect, Andrew. Thank you. I think with what we've seen the last couple of meetings, we'll be ready to do that, of course. And with that, we're pretty close. 12:25. We're looking at the RFP status update by Mercer again.
That's actually Brian.
Oh, right.
Yeah, thank you. So this is Brian Olson, the OEB and PEBB contracts team lead. This will be a brief update. As you know, we're still in the RFP process since no formal selections of winners have been made. So we're kind of under the same rules that there isn't a whole lot to share at this point. So what I can share is PEBB staff and Mercer have been working with our RFP advisory work group and the finalist interview evaluators to compile all of these final results and information and to work on a slide deck that we will bring to you for next week's board meeting, where we will ask the board to select winners for this RFP. So with that, I know that was pretty high level, but are there any questions? Great. Thank you.
Yes, Emily.
Yeah. Can you hear me?
Or people, yeah, okay. Yeah, back to the, I don't know, like a bigger picture kind of question that I have. I just know like, ICE is still going on in our community. There's a lot of, anti-immigrant, actions happening, at SEIU 503. We've stood up a brand new immigration committee, because our members, asked us to do that. I'm part of that committee. I'm also hearing a lot of issues of hunger, unprecedented levels of hunger, by, I don't know, our community members in Oregon. And so I'm just, wondering how like that kind of change in landscape is like gonna impact like our work here. It's just a, it's just a question. I don't know if others are thinking about this. How has it been impacting workforce even? We have a lot of bilingual, bicultural immigrant members of our healthcare workforces. And I know even at OHA, like a lot of our bilingual, bicultural staff are doing outreach, and they see the activity going on with ICE and, they're asking about their safety, and that kind. So I'm just thinking about those kind of bigger picture issues that will probably impact at some point, so.
Just a note on that. I mean, it makes me think about the law that passed in the legislature, and I wonder if there's anything we can hear an update around, but around ICE not being allowed in healthcare settings. And that was something we were hearing in the Salem area, that there was an increased presence of ICE around Salem Hospital at one point. So, it would be helpful to know, like, now that legislation has passed, is there anything happening to enforce it?
Follow up on that, Siobhan. I think with the release of the RFP, Emily, be a chance for the board to, submit some comments around what you're saying around disparities existing around the state and what the board's priorities are, and we can definitely help with that.
Okay. Thank you.
Thank you, Brian, very much for that very short update. I'm sure it'll be a little longer next week.
I like the term efficient, but that's just me.
Do appreciate it.
Thank you, Greg.
Do we want to do? Yeah, if we could, if we want to do a couple of short updates, is Glenn on the line? Glenn, if you could use a minute or two, and then
sure. Yeah, just wanted to update everyone. The April CL meeting we were looking at for the upcoming year, the OEB and PEBB, medical performance guarantees, dental performance guarantees, and the behavioral health network adequacy guarantees. Basically, for the medical, we had originally, in the beginning of the OEB renewal, had talked or Mercer had negotiated with the carriers about making some changes, specifically about really kind of having some stretch goals for certain PGs. It was decided that for the upcoming year, it would be best, due to the current focus on the renewal, and then also with PEBB and the RFP and the contracting, to leave the PGs as is for the upcoming year. And then in the fall, we can, at CL, can work on the, for the following year, making any changes. Very similar for the dental. The dental, we made some slight changes. And in the summer, we will be having a summer research group where we're going to be looking at all of the dental quality PGs, as well as access PGs. Behavioral health, there were some slight revisions that were made for the upcoming year. But again, it wasn't, a large change to those PGs. That was basically the focus for the April meeting. Were there any questions?
See any online, and there's none from the room. Thank you very much for that very pointed, quick update, Glenn. I appreciate it.
Sure.
We have Health Equity Work Group. Sharon?
Hello.
Yeah.
I'm Sharon Freeman, and I head up the Health Equity Work Group for the PEBB and OEB side. We had our first quarterly meeting last week on April 13th. That focus of that meeting was reviewing and finalizing PEBB and OEB's multi-year strategic roadmaps, and most of the emphasis was on our 2026 remaining efforts to clarify those moving forward. We did review the doula bill, SB 1568, and how it affects OEB and PEBB members and current carriers. So far, Mercer, Glenn Bailey, and myself have met with 2 of our 3 carriers to discuss how they're implementing and planning for 2028 effective date. And we meet with Providence likely later this week. As far as I know, we don't have a meeting yet. We also reviewed that work accomplished during the renewal process that Andrew reviewed for you, so I'll repeat that. I wanted to recognize and thank Teresa Cross for her contributions to the Health Equity Work Group over like the past 6+ years. She's made a huge difference with her continuous engagement and focus on individual wellness with that health equity lens. And although she's not replaceable, we will be bringing on another work group member when her position is filled. That's all I have.
Thank you very much. And Innovation Work Group, Margaret.
Yeah, thanks, Greg. Margaret Smith, some quick updates from the Innovation Work Group. The Innovation Work Group met last month, March 16th, and affirmed new leadership. So gave huge thanks to Kimberly Hendricks, the outgoing chair, and Robert Young from the OEB board, the outgoing vice chair, and affirmed new leadership. So Sally Duerfeld, who was on the OEB board from Eugene 1J School District, is now the new chair, and Sean Parkman from PEBB is the Innovation Work Group vice chair. So we're excited to welcome in the new chair and vice chair. The work group covered a couple of different topics. Did a sort of a check-in review and an overview of kind of the plan for Garner program experience and performance measurement. So a couple stats, as of last week, PEBB enrollment in Garner hit 21%. So that's great to see. The year-end goal is to have 40% of eligible members signed up for Garner. However, under the performance guarantee that's in place, we need to hit 20% by month 6 and 30% by month 9 to have that performance guarantee with Garner take effect. So we are on track. We're just about 4 months into the plan year, and we're already over that 20% mark. But continuing to monitor that as we want to make sure we hit those milestones and have those performance guarantees triggered. In terms of kind of some of the information that the work group talked about around performance kind of monitoring strategy, looking at aspects of member engagement and impact. So not only enrollment in terms of just sign up for the program, but the number of members who are seeing top providers, the number of members who are getting their cost sharing reimbursed, demographics and geography of users in terms of looking at different parts of the state and how utilization of the program is going, and also the types of providers and services that members are seeking through Garner. Another dimension of ongoing program review will involve clinical outcomes. And there we talked about mainly looking at HEDIS measures to look at quality of top providers versus other providers along various dimensions of quality of care. And then also the third dimension of measurement strategy is around savings. So looking at episodes of care for top providers versus other providers, risk-adjusted cost of care for members using Garner compared to members not using Garner, and then utilization and complications for members using top providers versus providers who aren't top providers. The expectation being that these are kind of the areas where, you know, Garner has noted they see a difference in terms of top providers and the outcomes. So wanting to try to track that in line with savings. And so the work group did talk about the ongoing approach for looking at those dimensions, noting that, you know, there is the measurement strategy does require that we accumulate sufficient claims data to be able to look back at a lot of these different measures. So it will be an ongoing multi-year strategy. And then another area of discussion at the most recent work group meeting was around collaborative strategies for PEBB and OEB to work together, leveraging purchasing power. We talked about some different aspects or approaches to reference pricing. In particular, talked about legislation that was passed in Vermont that limited reimbursement for medical pharmacy to 100% of the 120% of the average sales price. And so the work group talked a little bit more about that and is going to be looking at some different models for PEBB and OEB in regard to that sort of an approach in terms of essentially another iteration of a price cap. Also looked at other types of services that might have potential for reference pricing or price caps. And then the work group also continued some conversation around site neutral payments and high value provider networks. That high value provider network, I mean, think about like one iteration of that could be something that involved like say an expansion of something like Garner, where you're incentivizing use of a top tier of providers. So that's kind of an overview of what's been the recent discussion topics. The work group next meets next month, May 27th, I believe, toward the end of the month. And we'll have some continued discussion. I'll pause. Sean, did you look like you wanted to say anything? Or? Okay, great.
I had a quick question. So that 120% price cap, does that take legislative action or not?
So in theory, a reference price is something that could be negotiated, could always be negotiated. The examples that the innovation work group looked at have involved legislation in other states. So I think that's a conversation that the work group is continuing to have. There are examples of where reference prices are negotiated through contractual arrangements between health plans and providers. And then also, you know, the legislative approach is another alternative.
And the uptake of Garner, are we getting the numbers of the differences between the uptake on Moda versus Providence?
Yes, we are. We get monthly reports that show those percentages. And if you're interested, I got a report just last week. I got the March report. So for PEBB, the report for March indicated the total sign up was 20%, but I did talk to Garner just the other day. They said it's gone up a little since then. So it's closer to 21, 22% now. And then the MODA specific number for March was 19%. The Providence Choice number for March was 23%. And the Providence statewide number was 18%. So, and those are March numbers. So moving target. Thanks.
Okay. Any other questions? All right. If not, I want to thank everyone for staying on point and getting us through, even though we started late. Do we have any, I know we have several written comments from the board. Please make sure if you haven't to get through those. I know I did last night, night before. And then do we have any oral public comment, Rose? Anyone else that you know of?
Well, there was going to be somebody, but I'm not sure if she's here.
I'm just gonna go back here because we are.
Do we have Tiana Tozer online?
I have nobody in the hall, so.
I don't see her online, so
Okay. I didn't know
maybe she couldn't make it.
Okay.
I can follow up and see if they'd like to.
Yeah. I appreciate that. Thank you. With that, I was gonna say any other good for the order.
Yeah, I mean, I just want to note that similar to the public comments we received a month ago, we are seeing a lot of the same issues that we saw. I also read through all of the written public comments, appreciate people taking the time so that we know in detail what's continuing to happen with the folks that should be receiving their benefits. And we continue to see providers that are not getting paid. What's most concerning, I would say, is we continue to have members who are not getting the services that they're entitled to, particularly folks who are showing up to their providers and their providers are saying they're not getting reimbursed through collective health, and then they're being asked to pay upfront for the care that they should be receiving. So that problem is continuing. That's incredibly serious. And so I just want us all to take note that that is something that hasn't yet shifted and is hugely problematic.
You know, I agree. And I also want people to know that as a board, we are doing what we can to make sure that those things get together. Trying our best. Any other comment? Anyone online or in the room? All right. If not, then I hereby adjourn and close the meeting. Thank you very much for coming. And thank you for putting up with my first one. So I appreciate it.
Thank you. Well done, Greg.